I'm Sarah Parker. I'm fairly new to the urology department. I've been with Wake for about a year and a half with urology, so I'm super thrilled to be here and talk about this. I've had the pleasure of working with some of the best in the business, so even though I have a year and a half of urology, I've got lots of experience talking about this. So this is a slide here about summary of my life. I'm super avid pickleball player, so if anybody knows about pickleball, good for you. If you don't, I'd be happy to talk to you about it afterwards. So a little play on Halloween coming up. I'm not here to talk about trick or treat, but we're talking about tricks and treats today. Objectives for today, just 3 to highlight. Mainly, I'm going to talk about a way to be a more efficient workflow with our prosthetic urology patients. I'm going to talk about some postoperative concerns and things to be concerned about. And then also going to talk about ways that we can keep our patients from coming into the in-office multiple times. So my practice, even though, like I said, it's been a year and a half, I've done over 150 cases of our prosthetics with multiple physicians in our practice. I'm usually involved in every stage of it, whether it be pre-op. Some pre-op things that we go over are verifying A1Cs, and this starts in clinic. So we'll make sure their A1Cs are about below 8. We keep them off of anticoagulation, like aspirin, Eliquis, Plavix, things like that, and we'll make sure that they're off of them at an appropriate time frame. Also, the cardiac clearance, someone mentioned yesterday about that. I'm looking at those clearances and making sure that we have those before surgery. And I also order the pre-op antibiotics to be started in pre-op. Intraoperatively, luckily, I've had the pleasure of being a first assist in multiple cases, which has made me feel very comfortable about this topic. I prep all the devices in the cases, so that gives me good confidence whenever I'm teaching my patients about their devices afterwards. And then post-op, we keep our patients overnight. So I observe them in PACU, I go over discharge planning, and their follow-up with me in 4 weeks, which is all included under the 90-day global. So immediately after surgery, like I said, we keep our patients for 23 hours, so they stay overnight with us. We don't keep any drains in our patients or any compressive wraps unless they have grafting done with their prosthetics. And then, like I said, we keep our Foley in overnight. So for the AUS cases, obviously, they'll use a 12 French Foley. For device management, immediately after surgery, the AUS devices are left deactivated. So they have the catheter in overnight. They're deactivated at the end of the procedure, and so we confirm that with a dimple in the pump. Then IPP patients, again, will have a Foley catheter overnight because we leave their devices fully inflated. And then the next morning, we'll take down the device and remove their Foley catheter. For medication management, I always make it important to talk to the patient about their pharmacies and where they want me to send their medications to. But what I typically will send them, obviously, pain management. So these patients, typically I would say the majority of my patients I'll send home on tramadol unless that just didn't do anything for them post-op, day 1, or even immediately after surgery, but they'll go home on Q6 tramadol, so about 20 tabs, 5 days worth. And I wouldn't say I have ever had to refill after that. So antibiotics, typically 3 days worth of Bactrim, BID. Obviously, if allergic to Bactrim, we'll do doxycycline. And then we don't put them on any lifting restrictions. I really just tell them to listen to their body, don't do anything strenuous. No pump pulling, no trying to adjust, or obviously not trying to pump up their device until they're told to 4 weeks later. We go over no strenuous exercises. I talk to them about bathing. We have them bathe 48 hours after surgery. I tell them they can shower, use regular antibacterial soap, keep the area nice and clean. Obviously no hot tubs, bathtubs, pools, or anything when they're soaking in a body of water. After discharge, so triage nurses, we'll call them about 48 hours, so the day after they're discharged. We really try and encourage them to use the web portal if they have any additional questions. That's probably the quickest that they're going to be able to get to me. Most of their questions will go to the physician, which then gets forwarded to me. So then I'll answer them, call them if they need anything. But again, I'm the one they're going to be seeing at 4 weeks, so they usually like talking to me anyways. And then, like I said, 30 days later, 4-week appointment is follow up with me for a wound check, and if everything looks good, we'll teach them how to use their device then. Some postoperative concerns, but learning just how to operate the device. So like I said, I get to prep the devices in the OR, so I get very familiar with how the device works, how to manipulate a device if you run into any issues. But whenever you're initially pumping the device up, so cycling the device, it's really important to appreciate that pop. I don't know how many people have experience with teaching IPPs, but when you go to activate them or when you pump them up, the valve will move over and it gives you a good pop, and that's when you know that you're going to be able to inflate the device fully. A lot of patients try and grab their scrotum and tend to twist or kink the tubing, so it's very important to teach them how to avoid twisting the tubing. Some other physical concerns, I mean, everybody deals with patients that, have swelling after surgery, increased scrotal size or decreased scrotal size, and body habitus. So just trying to learn different ways that you can teach them to manipulate their scrotum to get good access to the pump. Then you always get questions, what happens if I'm in an accident or I need a catheter or I have to go get an MRI? So in our AUS patients, obviously we have to really be strong in instructing them that if something were to happen and they had to go to the emergency room or they're having back surgery, anything, somebody needs to know that they have an AUS. They need to see a urologist, needs to come and deactivate the device before any kind of instrumentation goes into the urethra. And then MRI, our devices are MRI safe or compatible. And then I always get that question, what if I go on the airplane and I go through TSA? Is everybody gonna know I have an implant? No, nobody has to know you have an implant. Video. Okay, so this is really good. So a lot of patients, I'm a female and I'm in clinic and I'm teaching them how to pump up their device. Some people are a bit uncomfortable when it comes to that. So I understand that, so we'll give them a QR code in clinic that if they feel more comfortable learning by a video and at home, then they can do that. And then I encourage a role of the partner. So a spouse or a significant other, anybody, if I see them in the waiting area, I will encourage them to come into the clinic with the patient and with me. That way they're there so they can understand how to use the device as well, because they will have time to where they'll be able to help deflate or inflate the device. So some tips, go over a daily cycling protocol. So what this is about 10 minutes long. I tell them after our appointment, I want you to cycle it daily for the next 2 weeks before you actually start using it. So that would mean you pump up the device, takes about a couple minutes, let it sit there, maybe try and pump it 1 or 2 more times, let it sit there for 2 minutes, and then deflate it. So the whole thing takes about 10 minutes. Some things that I've learned from patients actually is easier after a hot shower or during a hot shower, and also cycling while lying down to avoid twisting of the tubing. And then some things that I've actually learned in my practice is massaging over the deflation button if the pump ever seems stuck in a depressed position, which happens, not often, but sometimes where they're pumping the device up and the pump gets flat and they're like, I feel like I can't pump it anymore. And that's just because the valves got stuck. Just deflate it and it'll fill back up and just start over again. So when in doubt, just deflate it and you can start over. This is a video. So here you go. This is just a video for some of the patients that would rather go home and watch a video and not have some young female teach them how to pump their penis up. So here you can see on that right side there was the valve, so giving that good pump to the device is going to allow the cylinders to pull fluid from the reservoir to fill the device up. And there we go. 3 minutes, pump up. That's the protocol. All right, so some uncommon issues that some people run into is infection. So if they follow the post-op instructions that I give them, more than likely they're not going to get an infection. But you've got the antibiotics that they're doing. But again, I haven't seen very many in the first 90 days. Persistent pain, like I said, I send them home on tramadol. Haven't had to refill any requests on that. And then pump positions concerns. As far as the penis-scrotal approach that we usually do, I don't really ever see any pump position concerns when it comes to that. But we have had one patient with an AUS that it felt like their pump kind of was sliding posterior, and it was very hard to get to. Talking about curvature when it comes to our implant patients, this is something that definitely starts in clinic. So you want to talk about any kind of curvature before you get to the operating room, kind of have a good idea of what the curvature is, and if maybe it's something that we could just avoid grafting in the operating room and just do some modeling, that usually will correct itself. And then we may do some modeling. It turns out great, looks great. But then after 30 days, it's been flaccid, and then we go to pump it in the clinic, you'll notice that they have some of that curvature back. So it's important to talk to them about ways that you can self-model. So gently massaging the opposite direction of where the curvature is whenever it's inflated will help correct some of that curvature. And then graft care. So in patients that we have had to place a graft for Peyronie's disease during the pump placement, we'll leave these patients partially inflated at discharge. Like I said, we fully deflate most patients, but if we had a graft, we'll leave them partially inflated because I don't want to do any aggressive compression on the cylinders with the graft in place. These patients will have Coban left in place for 48 hours, and then after that, they can remove the dressing and take a shower, and they don't have to replace the dressing. So things that you may run into, urinary retention, we'll go over IPPs, AUS, and the sling. So after an IPP, we take their Foley catheter out post-op day 1 in the morning. If they fail the voiding trial, then they'll go home with a catheter for 24 to 72 hours, come back in the clinic for a repeat voiding trial. If they're still unable to void, then we'll teach them how to do CIC until the function returns. After a sling, very similar to the IPP, we haven't had to continue any CIC over the 90 days for the sling patients. And then for AUS patients, these are the most important population for the urinary retention. So if they fail the voiding trial post-op day 1, then we'll put in a 12-French Foley catheter at 24 hours max. I don't want the catheter staying in there for very long for the complication of erosion. So then we'll have them come back into the clinic. If they're still unable to void after that, we'll put a suprapubic catheter in, and then we really need to have a discussion on whether we need to upsize or uncouple the cuff if it's too tight. And then some things moving forward for especially our AUS patients, but initially post-op for some of our pump patients, we definitely want them to get a special bicycle seat or saddle. I tell a lot of our patients that mow their yard or anything, that they don't want to sit on a lawnmower the first couple weeks after having this place, because they do have the perineal incision when it comes to the AUS patients, and then the small incision in their scrotum when it comes to the IPPs. For a lot of our AUS patients, I am a big advocate when it comes to the medical alert bracelets. So luckily, our rep will bring the medical alert bracelets to the operating room, so I'm able to give our patients that then. And if not, then there are nicer ones on Amazon that they can go to and get minimal cost. And then they'll follow up with their physician in 3 months after they see me at 4 weeks. So some conclusions. We have this saying in the operating room, it's sweat or sweet, same way each and every time. So this is just the importance of standardization in a high volume provider experience. If we stick to the same way each and every time, it's easy to avoid the unnecessary in global healthcare. Communication is key in the operating room. Having staff that knows what you're doing, verifying, understanding with everybody in the OR is very important. And then satisfaction and improvement encouragement, especially with the AP or the APP with the IPP. So I think by me seeing patients pre-op, seeing them right after surgery, seeing them post-op day 1, and then seeing them again in clinic 4 weeks later, we've kind of developed a relationship. So usually at that point, with just some encouragement and seeing my face, it makes them feel a lot more comfortable. Thank you.